Hello, everyone. Good afternoon. Welcome to our Friday noon talk. Uh, Today we have the pleasure of welcoming Dr. Maritza Hobson. Maritza is one of our friendly faces from the MPU. She was a clinical physicist from 2010 to 2018. And now she is at Wake Forest University Medical School in her home state of North Carolina, working as an assistant professor. She's involved in the graduate program. She's also involved in AAPM Report TG334, which is what she's going to be talking to us today about. So with that, I will hand it over to you, Maritza.
Thanks, Pete, for that introduction. As Pete said, I'm just going to give an overview of AAPM TG334, which is a guidance document to using radiotherapy immobilization devices and accessories in an MR environment. And I was the task group chair for this. So I'm presenting on the behalf of my co-authors, who include MR physicists, radiation oncology physicists, people like myself who have worked with MR-guided radiotherapy. We also had a therapist and a vendor representative. So why do we need a document like TG334? One of the needs is because MR safety discussion historically has focused on the patient safety when there is an implanted device. For instance, implanted cardiac devices or orthopedic devices. Much less attention has been given specifically to devices used in the context of MR-guided radiation therapy, or MR simulation of the patient and treatment position. Okay, so I've included some slides on MR safety as a background and review to provide some context for TG334. So what is MRI? It's just imaging using magnetic fields instead of ionizing radiation. So as you can see, it provides better soft tissue contrast, and it can be easier to discern what, for example, here, the different spinal cord levels here. And what is an MR limerick? It's essentially just using MR imaging to provide patient localization, and also can provide intrafraction MR motion monitoring. Why should you care about MR safety? Well, really, there's no time not to be vigilant when around an MRI machine, no matter the field strength. And just a reminder, the MRI is always on. There are a lot of bad things that can happen if you don't think about MR safety. And even if you do, things can happen and you need to know how to react. Lots of devices look similar: MR conditional stretchers and oxygen tanks versus MR unsafe ones. That's why having a timeout process before entering MR zones 2 is important. Devices that might be below blankets for some patients could be forgotten and have unfortunate causes, such as here, there was a pulse oximeter left on this pediatric patient, which unfortunately caused this burn, as you can see. And then also why patient clearance is important, as you can see from the burns on the tattoo on this other patient. So there are 2 levels per the American College of Radiology for safety training of staff members. And these are also taken into account by and used in Canada as well. So a level 1 staff member is any staff member that could come into the MR suite. They're able to ensure their own safety in the MRI suite and not pose a danger to others. Typically, these are RTTs not involved with the MR or MR Linac, PAs, MAs, nurse, physicians, etc. A level 2 staff is an MRI scanner RTTs or other staff members who routinely work in the MRI suite. They have more MR safety training, and they're able to ensure their own safety and that of others in the MR suite. Okay, this is just a quick review of the safety level labeling. So an MR safe device is non-metallic and non-conductive and is safe in all MR environments. An MR conditional device with this like triangle here are devices that have undergone MR safety testing, and they have shown to pose minimal hazard in a specific MR environment. An MR unsafe device is unsafe in all MR environments, and it's also used to indicate the absence of MR safety testing. So there's a few caveats on MR conditional labeling that I wanted to show, and sorry, that should be capitalized, conditional. Just because one pacemaker or RT immobilization device from a vendor is MR conditional doesn't mean all types are MR conditional. Again, it goes back to the specific device. Now, the ACR safety manual was updated in 2024, and it's a wonderful update and provides more guidance than past versions have about specific scenarios, especially ones where there are MR conditional devices. It has this statement, which I'm not going to read the whole thing, but about MR conditional status. What we already have talked about on the previous slide, that it only applies to the tested model, make, and ID under specified conditions within the MR environment. So if a device was tested and determined MR conditional at 3 Tesla, doesn't mean it is at 1.5 Tesla or 0.35 Tesla, which is one of the MR Linac vendors' field strengths. The gradient slew rate that they mention also in the statement is also one that a lot of people forget to look at the specifications of your system for. This is important to keep in mind with some MR Linacs that do real-time tumor tracking during treatment, because there could be heating concerns that may not be present, for example, at for a device tested at 1.5 Tesla, not under the same gradient slew rate conditions. Okay. So with those reviews going over, the purpose of Task Group 334 is to provide guidance on the safe use of and integration of RT immobilization devices and accessories in the MR environment, including recommendations on MR safety labeling, testing, and evaluation of these devices for clinical use. This guidance document should benefit professionals with growing needs in MR-guided radiotherapy environment. So we worked with authors of TG284 and TG303, which were still in writing when forming TG334, to ensure there was minimal overlap. One was on MRI simulation and radiotherapy, and the other was an MR implementation and HDR brachytherapy. There are also 2 other task groups in progress that will also be related. Task Group 352 on MR-guided radiotherapy systems, which Dr. Levesque is a co-author on, and Task Group 345, chaired by Jason Stanford, which is on medical device considerations for MR safety experts. So those will be coming out in the coming years. Okay. So our first table in Task Group 334 reviews the subsystems of a typical MRI system with a superconducting magnet and their typical values. Now, I know this is small, but I mean, why are these important for your system to know for your system? Again, these are 2 small tables, but these are 2 tables from Task Group 334. Table 2 on the left is taking those subsystems of a typical MRI system discussed on the previous slide and showing their specific considerations and safety risks. And then table 3 then goes back to the relevant MRI system specifications for MR safety assessment of devices. So it's just knowing these specific values for your MRI system is important. Then when a device or accessory has been given the MR conditional labeling and you have the product sheet with those labeling conditions, then you can tell if it matches your system's specifications. So in preparing our task group, we reviewed guidelines from the FDA, ASTM, and ISO standards on MR safety. Dr. Levesque also reached out to a contact at Health Canada Medical Devices Evaluation Bureau. Based on these reviews of the different documents, Task Group 334 proposed how ASTM and ISO standards could be applied to RT immobilization devices and accessories. So given the specific knowledge and equipment needed for MR safety testing that every clinic isn't going to necessarily have, the authors of TG334, we recommend that RT immobilization devices or accessories to be used in an MR environment be purchased from vendors with the MR safety status already determined. Then you can use, the end user can use Section 2 of Task Group 334 to ensure that the documentation that you receive from the vendor is sufficient for your clinic's needs. So scientific rationale is also used. So say RT immobilization device or accessory lacks specific MR safety documentation. Per ASTM recommendation, scientific rationale can be used to establish that a device is MR safe. So when can we do this? When the RT immobilization device or accessory is composed entirely of electrically non-conductive, non-metallic, and non-magnetic materials. So once you're ensuring these criteria are met, that means that a magnetic force and torque are no longer of a safety concern in an MR environment, as well as the risk of heating caused by gradient and or RF field interactions. Those are reduced. Sorry. So what if scientific rationale cannot deem the device MR safe? It does not have MR safety status already determined, and there is not on-site MR safety testing expertise and equipment. So in this case, we recommend the device be sent out for testing to a site that has the required equipment and an ISO accreditation for MR safety testing. So I'm just going to highlight some of the key points on applications of the ASTM standards to RT immobilization devices or accessories. So when you're applying ASTM 2052, the test for measurement of the magnetically induced displacement force, you're performing it outside of the bore, so as by this diagram here, with a device suspended by a string. Obviously, like a lot of our mobilization devices and accessories are way too large to suspend by a string, you know, like the back locks or wing boards. It's just unrealistic. So as we stated earlier, these devices should be considered MR unsafe unless they can be determined to be MR safe by scientific rationale. So like make sure they're non-conductive, non-magnetic, etc. Okay, so when we're applying ASTM F2182 for evaluating the heating concerns, the RT immobilization device or accessory should be placed with a phantom in an MR system. So why do we recommend a phantom? This is from our task group recommendation. It's because in ASTM F2182, it states that the RF heating test of passive implants require that the devices be submerged in a test solution to mimic in vivo implantation. So that's like, again, just as a reminder, these testing parameters are for implanted devices, so small devices. Obviously, we can't do that with external RT immobilization devices and accessories because it's just impractical. The bath would be too large, and we probably couldn't, after we take it out, couldn't use the device because it'd be all sticky and who knows. So we recommend that external RT accessories and immobilization devices undergo RF heating tests that mimic the situation that they will be used in by using a phantom placed beside it. And that phantom can be made of, inside of it, can be made of the formulations provided in ASTM F2182 for that liquid. And then the scanners are used to perform this test should be clearly stated in whatever report comes out, whether it's in-house or external testing. To clarify, scanner SAR is calculated from a model and usually includes a conservative margin for safety. Thus, there can be a difference between the scanner SAR and your measured SAR. That's why it's important to have indicated on that report what SAR it's saying for, so you are sure it's adequate for your MRI system. So if you send out the device for testing, specify what usage conditions of the device are and the orientations, because that's important for heating testing, and the expected SAR levels and what SAR is being used in your system. So we go into great detail of all the things you need to think about for this test in section 2 of the report, and I'm not gonna go over that today. Okay. So then this is determining the measurement of the magnetically induced torque, which requires the torsional pendulum shown here in this figure. So these all we recreated from ASTM documents with permission. So, which not all centers or even universities have this type of system. It's pretty complex, right? And like there probably isn't going to be made out of MR conditional or MR safe materials. So that underlines our recommendation to get devices where the MR safety status is already determined. Also, the testing platform, it has to be allowed to come to equilibrium before the whole testing apparatus is placed in the uniform magnetic center of the MRI system. So like imagine you're trying to put a wing board on this thing, and then you're trying to move it, let it come to equilibrium, and then make sure it doesn't move when you go into the bore. So obviously that's crazy, right? So it's not really going to work for large bulky devices. Okay, so this also underlies our recommendation that the bigger devices or accessories be constructed out of MR safe material. Okay, now we're on to the evaluation of MR image artifacts. So given that MR simulation and MR guided radiotherapy images are used for tumor delineation and or treatment, image quality tests in the presence of RT immobilization devices and accessories must be performed before using them with any patients. It can't be like just forgotten about. So if the MR safety status of a RT immobilization device or accessory has already been ascertained by the vendor or an accredited facility or in-house, it is recommended that the image quality testing be repeated with the institution's RT-specific MR protocols, and the RF coils to be used with the RT immobilization device with proper coil filling with a phantom and similar setups to be used as in clinical use. That allows us to properly ascertain any potential imaging artifacts, including field of view limitations, which may lead to our aliasing artifacts. So we're more using it in how we would clinically, right, with our clinical protocols. So section 2 gives detailed instructions on how to determine the worst case image artifacts with that. Then a qualified medical physicist can then determine if the RT specific protocols need to be modified, if they can be, without decreasing image quality. When a specific RT immobilization device or accessory is used, for example, to increase the signal to noise ratio or adjust the field of view. But if there are sizable artifacts affecting target or OAR delineation, the RT immobilization device or accessory should not be used, or specific use considerations should be specified. So for example, if you have an artifact on the edge of the MR field of view, that may be clinically acceptable for lesions located midline, so the pancreas, but may not be appropriate for lateral lesions such as the liver or breast. Now, one thing too is like from working with MR guided radiotherapy, that also affects your treatment planning too. So that's one thing to keep in mind why you might want to do this test in different orientations, because it's not going to be exactly the same every day with the patients, even with the indexing, okay? So off-label use. If a device is marked as MR conditional and is to be used outside of the MR system specifications that it was deemed MR conditional by the vendor IFU, the RT immobilization device or accessory must be assessed for off-label use with the testing methods provided in section 2. So for example, for a device that was deemed MR conditional at 1.5 Tesla, but needs to be used at 0.35 Tesla, then that's it. Modifications to RT immobilization devices, such as replacing the metallic fixation with MR safe components or adding risers or holders to accommodate RF coils. So these are the two examples of off-label use, okay? So the assessments for MR conditional status must be well documented in the acceptance documents of the RT immobilization devices and must state that the device is being used off-label of the vendor's recommendations. Again, this is why it's important to know your system's values and stated in the table shown previously. So one thing to keep in mind, if you do these modifications to an FDA approved device, that may alter the performance of the device in unexpected ways, not just from the MR safety aspects, but also the mechanical aspects, right? So you need to be cognizant that the burden of liability lies with the user and your institution, and that vendors may not provide support or service for a modified device, and the warranty could be voided. So you need to consider the mechanical integrity, because one screw may not be the same in terms of what load it can hold, the general safety and MR safety of the device. If the status is determined to remain or become MR conditional, the user must establish and document the updated conditions for safe use of the modified device prior to clinical use. So just one thing is that we as authors of the task group 334, we can't condone off-label use liability-wise, but we acknowledge it is clinical practice in many institutions, even our own. So, however, the burden of liability will rest with the institution to ensure that the appropriate and thorough MR safety testing, acceptance, and documentation are performed. And we, again, the authors of TG334 also strongly recommend that the readers refer to AAPM TG121, which discusses the responsibilities of the medical physicist when using the medical products off-label. So one thing is that just, this is one thing to make sure you cover yourself in terms of those things, because you're doing what's best for the patient, but you just need to make sure that if something happens, you covered all safety aspects, okay? So this is our suggested workflow of how to determine the MR safety status of a RT immobilization device or accessory. And that we just worked through, going through all the different sections of what our recommendations are. Okay. So for the departmental policies and procedures, that we recommend that the MR Safety Committee provides training, competencies, policies, and procedures on the safety checks, acceptance, and handling of MR simulation and MR-guided radiotherapy with RT immobilization devices and accessories. And we also recommend that due to the similar appearance of MR safe or conditional and MR unsafe RT immobilization devices and accessories, a policy that only devices with MR safe or MR conditional labels are permissible to enter and be used in an MR environment. So this can be considered restrictive and expensive recommendation. However, this is one of the failure modes that can be seen in that slide that I'll show you, where MR unsafe stretcher was brought in because it looked like an MR conditional stretcher. So you don't want that to happen. So, okay. We also wanted to acknowledge the importance of this statement in the task group, that reading our task group does not replace formal MR safety training or certification. That really needs to go through your MR safety committee needs to be established. You need training for level 1 and level 2 users. And you need an MR medical director or MR safety officer, MR safety expert. So who can make these decisions in this flow diagram then? We provided a suggested table of staffing roles for level 2 MR personnel when determining the MR safety status of the RT immobilization devices or accessories. So please note that these roles can be adjusted based on internal credentialing processes at your institution. So I just want to underline that all the people that can make these decisions have to be as level 2 MR personnel. So it's not anybody up in upper management unless they're also a level 2 MR personnel. Okay. So the final MR safety designation, it comes from regardless of where the device has gone through MR safety testing, or if it already comes with MR safety labeling, the final designation should be reviewed by the MR safety officer in consultation with the MR medical director and MR safety expert before it's used on the patient. So that's the final say there. Once we establish the MR safety status of the device and any possible artifacts have been established and disseminated to the end users, the RT immobilization device or accessory should be added to the departmental inventory. And we gave examples of an inventory record at initial acceptance and one like when there's a modification or replacement occurs. Okay. Then Appendix C is a summary of the recommended tests and steps for initial acceptance, daily QA, and annual QA of your RT immobilization devices and accessories you'll use in the MR environment. We wanted to highlight that we recommend when first accepting an RT immobilization device or accessory, then an X-ray or CT should be acquired before it enters the MR environment to ensure there are no metallic components. This goes back to that MR unsafe devices can look extremely similar to MR safe or conditional devices. So the wrong device could be sent to you, even if it could have been labeled. It's just like a sanity check, okay? So we also recommend that annual and initial MR safety training of level 2 personnel should include ensuring staff are aware of the associated artifacts, kind of already said this, sorry, and limitations with any of their RT immobilization devices or accessories. Like you want to make sure there's clearance. That's what I mean by limitations as an example. Or if it can be indexed at one part on the treatment bed and not the other. Okay. So we already touched on the fact that we recommend the user purchase devices that already have a documented MR safety status, but here are some additional considerations I'd like to mention for vendor devices. There are purchase considerations. Obviously, something I just talked about, the bore size of your MR simulation or MR guided radiotherapy system that's going to be used. Can the device fit through it, not just the device, but also with the patient? And what size patient? In terms of the separation, if you have to have it on an angle with the patient with their arms up, okay? Can it easily be secured to the tabletop for any of the systems that it will be used? So some of the systems, they don't have the same indexing that like from your CT, so that's one thing to consider. So this, if it has the same indexing, that will allow us to minimize the differences between the MR guided radiotherapy or MR simulation and the visual treatment system, okay? Again, is it MR conditional for your MR simulation or MR guided radiotherapy systems? There are also single-use devices, okay? We need to pay particular care for these devices to ensure that the MR safety status from the vendor does not change from device to device or batch to batch, because sometimes that can just change for things, okay? Okay, why do we not use a lot of carbon fiber with MR conditional or MR safe RT immobilization devices or accessories? It's because it's electrically conductive and may potentially burn a patient. It can also adversely affect the image quality, so the signal to noise ratio or the uniformity. So DABR et al. First looked at phantom studies where they showed that for 2 different coil configurations that this SNR and uniformity both decreased when the carbon fiber insert was present. You can see those numbers in these tables if you can see that. You can visually see though, it's a little bit easier, that when the carbon fiber flatbed was inserted, that there's a huge shadowing artifact on the bottom image right here. Okay. Compared to when there's no carbon fiber. So all clinics probably have legacy devices or in-house patient-specific devices, which may lack proper MR safety documentation and will need to undergo MR safety testing following the standard acceptance procedures discussed in Task Group 334, either by in-house if possible, or really what's recommended, sending it out for testing. Why do I mention this section? Because if departmental supervisors or management are used to in-house cheaper solutions being made, they may not recognize the extra work, time, or resources needed when trying to incorporate such devices in an MR environment. Usually it's kind of like they just want you to use it. Oh, it doesn't have anything in it. And really you need to take a time out and take your time, because worst thing is that we could have a incident happen. Okay. So also in-house patient-specific devices are often used for particular cases. So it's only one patient that may need it. So these can include 3D printed devices made up of some common thermoset or thermoplastic materials, which sometimes need bonding agents to hold them together. So this is one of our figures in Task Group 334 from one of our co-authors from her PhD thesis. So this demonstrates that the use of the correct bonding agent is important to prevent artifacts. So in the center here, this was Loctite super glue was used to adhere this brass spear here to the bottom for testing. Okay, so obviously that created a artifact and signal void here, where if we just use a hot glue gun, which is probably also cheaper, there was no signal void. Okay. So construction of new in-house devices or modifications of vendor devices. If you do either of these, you need to make sure you maintain records of what materials were used to create devices in-house or modifications to vendor devices. And if there's any new in-house device that you're going to be constructing, you should make sure you evaluate it for board clearance, again, including the patient size. And we strongly recommend that it not possess any additional MR safety or imaging artifact concerns. Then it's just easier on you in the long run. And that we strongly recommend that they are made out of parts that are MR safe, preferably by scientific rationale. Okay. Oops. Anyway. So these are some additional MR guided radiotherapy additional considerations. Now we included this section because the task group for MR guided radiotherapy was not formed yet. So we wanted this in here too, and not just us, like all the review committees wanted this in here. So we'll be getting more from them probably too. So there are additional like safety concerns, and their potential clinical impact is not always MR safety, but it could also be related to the patient dosimetry. Okay, so when you place the surface coil on the patient, you want to actually, here's some great examples. This is one of the from the MR Linux system that I've used. The positioning of this coil is important. Not sometimes you want to make sure that because you don't want any attenuation through things that weren't in there from your MR simulation. It's pretty similar to like you want what's in the scan to be exactly where it is for even a CT sim scan, okay? Because it could lead to differences in attenuation along the beam path versus the setup, okay? Not different really from CT sim, but sometimes because of these parts, you may not like, because of your limited field of view, you may not like be thinking about that, okay? Okay, these are two examples of coil configurations with MR-guided radiotherapy patients. On the right is the patient setup with, so the posterior coil is actually right underneath the patient here, and then there's the back lock. And then you have the anterior coil here placed on top of them. And they're strapped together with Velcro. So we do this so you minimize the distance between the coils. So that increases your signal to noise ratio. Because, I mean, because there's no coil built into the table for these systems like you would see on an MR simulator or just a straight up MRI. Okay. And then for head and neck, obviously, for these systems, there was no head and neck coil initially. So they came up with using it this way here. But also, even with the coils, sometimes they wouldn't fit with the RT, like the head and neck mask and everything, okay? So this is what they came up with here. Oops, I keep on going the wrong way. Sorry about that. So we recommend this workflow for MR-guided radiotherapy additional consideration. So first, you already determine if it's MR safe or MR conditional for the field strength to be used. And then you go through the additional considerations like if the electron density is available, if not, perform a CT scan to get it. And in terms of, we do manual electron density overrides and everything for that. Okay. So there are some unmet needs and future directions after the compilation of TG334. So I kind of like reiterated a couple of times that all the AAPM standards right now are for implanted small devices. And we've provided examples of how to apply the current AAPM standards to RT immobilization devices or accessories, but these are not official AAPM standards for external devices. To ensure adequate and consistent MR safety for patients in this situations, it would be beneficial for the MR-guided radiotherapy and radiotherapy communities for a consistent document detailing design principles of MR safe or MR conditional RT immobilization devices and accessories for different treatment sites and diseases so that these patients could be served faster. Now, I've been kind of harping on the MR-guided radiotherapy and radiotherapy communities, but it's also good for MR, just the diagnostic MR physicists, because sometimes you don't have a separate MR simulator, you don't have a separate MR-guided radiotherapy, and then sometimes the patients are sent, as some of our authors got, over to just a diagnostic MRI, and the MR physicist is just like said, hey, make this work. So this would also help them, right? Okay. So as I showed previously with the MR-guided radiotherapy slides with the coils, some of the current coils or bridges available may not be optimal for all patient setups, especially with more bulky RT immobilization devices. Thus, the development of RF coils or bridges for these instances could be investigated so that the image quality could be improved in these instances. So we got one question after the publication, so I wanted to throw that in here. Is there a recommended brand or vendor of thermometry probe to use for the RF heating testing? I didn't go into detail on this test, but so one of the diagnostic MR physicists said he's used the same probe for 16 years, and it's any fiber optic thermal sensor would work. Okay. And then I kind of like harp on this a lot. Excuse me. why can't we assume something? This wasn't an actual question. I just I know this comes up in people's mind. Why can't we assume something MR conditional at 1.5 Tesla or 3 Tesla is at lower field strengths? Well, again, I keep on reiterating it. It's not only the field strength that matters. So recently, Gosh et al. Detailed an MR safety program in their department, including how they cleared devices for their 0.35 Tesla MR Linux system. So they put in their safety protocols, procedures, and documents in place for this situation. And I did something similar for our MR-guided radiotherapy system that I worked at previously. So this is one of our recommendations in TG334. With the lower field strength MR Linux having to perform these extra steps of clearance of a device, either internal or external, will occur quite frequently. So it is imperative to have a documented departmental process with the parameters as listed from Table 3 for your system, so that it's easy to determine if the device is MR conditional in your MR system. So I did that for our system, and it helps out. Then it's also like if you go on vacation, then someone else that has been trained properly can also do that. Okay. So the ACR MR Safety Manual from 2024 also has a chapter labeled Alternative MR Environments, which includes MR Linux. However, they don't specifically address the clearance of devices and the lower field strength, just that the device used should be MR conditional for the MR environment employed. So obviously we still need more information from them, but this is more than they've had previously in their recommendations, so it's a step in the right direction. Okay, where are the ISO accredited labs that perform MR safety testing? So there's a few facilities in the US that provide MR safety testing. You need to make sure that they have ISO accreditation, particularly related to ISO/TS 10974. That's the number for what we need for MR safety testing, and that they can perform all the ASTM tests at their facility with the size of the RT immobilization device or accessory you would like to be tested, and maybe hopefully as close to your MR systems values that are shown in Table 3. If you can't use carbon fiber when making your own in-house device, what can you use? So instead of carbon fiber, an example given by Langmack is the use of polypropylene and fiberglass composites. So in their paper, they measure the 6 MV X-ray transmission and buildup properties of carbon fiber versus the composite PFGC, and found that it had an X-ray transmission and buildup property similar to carbon fiber. So there are materials out there, just may take some research and everything. Okay, so in conclusion, we've provided practical clinical recommendations and actions that medical physicists and other qualified health professionals practicing in MR-guided radiotherapy and MR simulation can take to support and safely integrate into these hybrid environments. We have proposals on staffing involvement, training, and responsibilities. And we're expecting this is going to function as a guidance of future development in the MR safe for MR conditional RT mobilization devices and accessories as the field of MR-guided radiotherapy continues to rapidly expand. So these were just some disclosures of conflicts of interest. So that's the end of like the scientific part. And so I'm just going to talk about like how we got to, if I think I have time, the formation of task group 334, because I think it's important as graduate students to know like how you get to that place and stuff. Okay, so I was a member of AAPM Vendor Relations Product Usability Subcommittee back when I was a staff/faculty member at McGill, and the chair of that committee asked for ideas for publications from the group. At the time, Dr. Levesque and I were actually looking into I think, one of the mobilization devices there at McGill, and there was not a lot of information. And what there wasn't grouped as a guidance document. So I proposed the idea back in 2016 to the subcommittee with a formal proposal in April 2017. So looking back through the emails this week from the vendor relations subcommittee, I saw the idea was ranked last as a group, which is kind of funny, but we had a diverse group of people. It just wasn't in their interest. However, I just want to make sure that everyone knows it's the only one that made it to the task group stage. But also, like, I got a lot of support from the subcommittee chair, Gig McGarris. And he really pushed it forward. He really supported me. And I actually didn't meet him except for like one time in person. So we formed a group out of the vendor relations subcommittee members, which included both therapy and diagnostic physicists, to really formalize a proposal, which then we presented to, again, the vendor relations group around 2018. After that, the proposal for the task group went through many committees for comment before it could go for vote. So the MR subcommittee, the therapy imaging subcommittee, clinical practice subcommittee, professional council, and I'm sure there were more. It's just all the emails I was getting lost at earlier this week, where there are many comments and suggestions of other authors from these comments and what we should and should not address based on the other task groups that were pending publication or already in progress that I mentioned previously. So we got two representatives from TG303 and TG284, Gil Cohen from TG303 and Carrie Glide-Hertz from TG284. And then it even went through Science Council as well, because it had been decided, not by me, that it was going to be a joint professional and Science Council task group. So we had a formal voting starting in September 2018 through the committee, which was, then we had final approval for the formation in January 2019. Okay, so one thing I want to say is that they tried to speed up the process quite a bit since this. Okay, so a lot of the AAPM task groups have in-person meetings at the annual meetings, so RSNA, et cetera. So January 2019, we were approved. We started working. We had an in-person meeting in the AAPM in July 2019. However, in the spring after that, obviously COVID-19 happened. So it didn't just change like how like we all work in the clinic and everything. It also changed how we approach these types of situations as scientific, groups, right, and committees. So we're also dealing with a lot of constraints as individual like committee members at home and in the clinics. And Dr. Levesque and I at least had one video phone call, which definitely helped both with the task group, but also helped me seeing someone outside of my immediate work and family. So, okay, let me get past that. So initially we set up quite a few meetings to hammer out our outline and what we were covering. And I'd assigned members with different sections, like a lead for each section. So that wasn't all on one individual. And I hope it worked, that no one was too stressed. I didn't get any complaints, really. And we had timelines for certain sections to be done. And during this time, our parent committee actually was switched to administrative council. We're not really sure why. Anyway, in July 2021, we had an overall draft for internal review after I put all the sections together and did some editing to do it. And April 2022, we submitted to our parent committee to start the review process. So once you start the review process, that takes a while. And because of the council change, I also added in a review that I wanted because I thought it should, for good scientific reasons, and review go through the MR subcommittee. So I slowed us down for a while, but I stand by that decision. So then after it was through all the committees, it went through concurrent review from medical physics, where we got 2 more reviewers in July 2023, and then also from AAPM Executive Committee. And it finally got published in March 2024. So 7 years. Why did I go through that all in detail? So I'm just showing this all to say that we did a great job, all things considering, and these task groups take time, even with the writing and everything. Patience is something you have to try to have. And I know I'm not the best with it, as some people here know, but you just have to think about the process as a pay-per-view amped up. And once you submit it, just wait, do other things. We also have to remember for these types of organizations, such as AAPM, they are volunteer organizations. We all have full-time jobs outside of them. I also want to point out that some of the co-authors I have never met before in person and became good friends during this process. So one I text almost on a daily basis. And I also want to point out that you don't have to be you don't have to be out of grad school to volunteer on committees, either for AQPMC, Comp, APM, RSNA, ISMRM, any of those. You can get out there and get active if you want. It can help you network, but it also can maybe open you up to different ideas. Not that what you're learning there at McGill is great. But having different views on things is always good. Okay. And then also, like, don't feel like you need to be the expert on, but considered by the larger community before you can make processes in our field better. I definitely am not an MR safety expert by any means, but I've learned a lot, especially from Dr. Lebeck, and he's helped me tremendously through everything. So it can also give you connections that you can phone a friend if you're in the clinic, if you're doing research later, just to like go over something, get a different perspective again. And then lastly, I didn't actually propose this idea to become a task group chair. I didn't know it would turn into this. I thought we could put a nice white paper together, be quick and everything. So sometimes things can get out of control, but in a good way. I just did it because I saw a gap in the knowledge for someone like me to easily understand. And ultimately, we're helping our patients. All right, thank you.
All right, thank you very much, Maritza, for a good summary of the report, and then also giving us a little behind the scenes look at how a task group gets formed in the first place, which, I mean, I just assumed they were there, right? But you're right, someone has to propose it, and you showed the amount of effort and work that goes into just getting one off the ground, so good for you.
I have to admit, I was like, oh my goodness, it really did take that long.
Yeah, although I guess, I mean, that is a long, on the scale of grad school, that's a long time, but on the scale of certain projects, I mean,
yeah, it's not really that long.
It's under 10 years. That's not so bad.
Yeah. That's what, like, someone like Dr. Glidehurst, she kept on being like, you got it out like after approval within 5 years.
That's I just know, I think it was last year, there's a task group, TG150, which is for diagnostic radiology, digital radiology QA.
Yeah.
It was like 10 years delayed and it just came out.
Yeah, and that's why I say, like, you have to realize, like, we're volunteers, we're doing our best, and like patience, we need to have patience with one another. We're not, yeah.
Yeah, this is people doing things in their spare time.
Exactly.
And you have to adapt to changing information too. I know if you might have an idea that starts out now, and 5 years later, well, actually, it's not so relevant anymore. We need to modify.
So like there was another MR-Linac vendor that came on that I had to make sure, like, so I made it generic, so it wasn't vendor specific, so not to cause any issues.
Yes.
So yeah, you got to be vendor neutral. So even with the vendor relations subcommittee.
Makes sense. All right, we have time for a few questions for Dr. Hobson. If anyone has anything online, feel free to type it in the chat or say it out loud. in the classroom, feel free to just ask it. A lot of info. I had one note I made, and I'll ask it now. Just the measure you talked about, the measurement of scanner SAR. Is this something that's commonly done? Like, I'm not very familiar with MR to begin with, but to me, I was like, oh, it sounds like you're doing CTDI measurements, but for the MR.
Honestly, like I said, I'm not an MR safety expert. So that might be a question for Eve to answer better.
Okay.
So, because I was like, there's differences. Like I learned quite a bit like from the diagnostic MR physicist. So yeah, like, well, okay, so there's the SAR that you can measure with the probe, right? Or that, but yeah, let me go back to that. So and then the estimated, I likened it to what's that one on ultrasound? See, it's been so long that I've been in ultrasound. It's actually sad.
Like the thermal index in ultrasound?
Yes. Like, it's like there's those, but they have a huge safety margin like worked in, right? Or the RF power. That's what I was thinking about, the RF power. So that's what I likened it to. Like, there's the measured one, but then like what it displays is maybe with a huge margin on it, right? So yeah. So yeah, okay. The scanner SAR is from the model, and it's like the RF power, like with the margin. But then what you measure is probably going to be a lot lower, right? So that's why it's like, because if you're like, oh, we're way below it, or like, wait, or it's just need to know what matches, because you don't want to mistakenly do something wrong.
No, I mean this is one of the ways where you can actually affect a patient with heating them up too much.
Yeah. There are like, we didn't talk about it, but the ACR manual also talks about like for MR conditional, making sure that like, because there's like the safe mode on MR scanners, and then there's the like expert mode for SAR, and I would never go to that mode. Well, I don't scan patients anyway, but like we don't touch any of that, even with our MR techs that are excellent here. So yeah.
Okay, thanks.
Yeah.
Anyone else with a question for?
It's a bit of a dry topic. It's okay.
I mean, you covered everything.
But yeah.
Is the report? I mean, the report is out. If people read it, it's
out.
available.
Everybody, you can read it and fall asleep to it. I know I did when I was reviewing it again myself. But I have to say, and I'm not biased at all, but I am. It's pretty well written.
Good.
But yeah. By the way, you should ask Steve to do a talk too.
Sometimes you just need a good reference document. It doesn't mean you have to read it cover to cover, but you have a place to go and look something up when needed.
Exactly. So that's what this is for, not that you need to read it. So.
Excellent. All right. Well, if we don't have any questions from the audience, I'd like to thank you once again for speaking to us.
Thank you.
If you're ever in Montreal, please come by. You'll probably notice things have changed.
Yeah, we're not going to be crossing the border because we're afraid to get back in.
Right? I mean, unfortunately, same thing, opposite direction. Oh, well, unfortunately.
Yeah, we want to come home a bit, but yeah, we're afraid about getting back in with our dual citizenship.
Okay. Maybe eventually in the longer term.
Yep.
All
right.
Well,
thanks.
Thank you. And
anybody can reach out to me too.
Yeah,
okay?
That's right. We can put you in contact with Dr. Hobson if you want to.
Yep. Okay.
Thank you,
right,
and
thanks.
have a good weekend, everyone. We'll talk to you all later.
Happy Victoria Day weekend, right?
Victoria/Patriots Day. Quebec.
Oh, right.
All right. Bye, Maritza.
Okay.